Hey everyone, it's Nurse Sarah, and in this video, I'm going to go over nursing pharmacology questions to help you prep for your NCLEX exam. So let's get started. Our question says, we have a 36-year-old patient who has been admitted to the ER exhibiting extreme diaphoresis, shivering, muscle rigidity, and irritability. The patient's heart rate is 140 beats per minute, and temperature is 102.6 degrees Fahrenheit. Their medical history includes depression, diabetes, atrial fibrillation, and hypertension. Family members report the patient has a persistent dry cough and has been using an over-the-counter medication to alleviate it. The patient is currently prescribed sertraline and is also taking the medications below. Which medication should the nurse promptly notify the healthcare provider about? When we look at this scenario, there should be a couple things that jump out at you before you even look at those options. First is that something's definitely going on with the patient. They're extremely sweaty, they're shivering, they have muscle rigidity and irritability, they are tachycardic and hyperthermic. So you read a little bit further, and then the second thing that should jump out at you is that it says that the patient is currently prescribed sertraline, and then these other medications below in our options. Therefore, you want to think back to what sertraline is. This is part of the SSRI family, which stands for Selective Serotonin Reuptake Inhibitors. And let that name help you, because it literally tells you how this medication works. Because in a nutshell, what sertraline is going to do is it's going to increase the availability of serotonin in your brain. Because remember, serotonin is supposed to be one of those happy hormones, which helps you be more positive, be calm and focused, which should help treat depression. And we see that in this scenario, the patient does have a history of depression. But unfortunately, based on how it works, and if we take other medications that sort of have a similar mechanism of action, we can have problems. Because how SSRIs work, once you picture in your head a neuron, we have our neuron and we have like our synaptic cleft, and raining down is serotonin, our happy hormone. And what an SSRI does, it's a selective serotonin reuptake inhibitor. It's going to inhibit the reuptake of serotonin. So we have more serotonin hanging out in that synaptic cleft, hence giving more available to your brain so it can help combat the depression. Now what we want to do is we want to look at these medication options and see which ones could potentially do that as well. So A, glyburide. This is an anti-diabetic medication. It does not affect the serotonin pathway that we just covered in a very simplified way. So we can go ahead and mark that off. Then we have B, dextromethorphan. Okay, this medication, this one's making me wonder because it is an over-the-counter cough medicine here in the US that we have, and how it works is it suppresses coughing, and it works on your central nervous system so you don't cough as much. But it could also affect serotonin levels, making it more available at that synaptic cleft. So if we have a patient taking this plus their SSRI, we're going to get serotonin overload, which the fancy term is serotonin syndrome. And the signs and symptoms that the patient has is classic of what serotonin syndrome is. So we're definitely keeping this one. And then C, metoprolol, that is a beta blocker. That works on the beta receptors in your heart and so forth. So we can mark that off, doesn't have anything to do with serotonin. And then D is lisinopril, that is an ACE inhibitor. Again, that deals with the RAS system. So we can mark that off. So our answer is B. Here we have a patient who has been taking simvastatin and reports to you they are experiencing soreness and weakness of the muscles. The healthcare provider orders lab work. What lab result below will you immediately report? We have A, increased high density lipoprotein level. So this is talking about an HDL level, and we can measure this on a lipid profile. We can look at the HDL, the LDL, triglycerides, and so forth. And it tells us the patient's overall risk of developing cardiovascular disease. So is this something that would alarm us if a patient had an increased HDL level? Well, let's look back at the scenario of the medication that they're taking. It's simvastatin. Simvastatin is part of the statin family, so let that generic name help you, that last part of it, and it helps lower cholesterol. So are we alarmed that our patient has a high HDL? The answer would be no. We actually want this level to be high, which is crazy, right? Because Whenever we're looking at labs, we want them within range. We don't want them too low or too high, but this is an exception. We want it to be higher HDL because HDL is one of the good cholesterol levels. It helps us maintain a proper cholesterol. Typically, depending on the lab, you want it greater than 60 milligrams per deciliter. So I'm not alarmed by that, so we're going to mark that one off. Then we have B, decreased creatine kinase level. So let's review what a creatine kinase level is. Well, this is one of those markers we can measure from the blood that tells us if we have damage to our muscle. It tells us about skeletal muscle damage, but it can also tell us about cardiac muscle damage. So we're given in this scenario that our patient is experiencing soreness and weakness of their muscles. And unfortunately with statins, what I want you to take away whenever you're studying this class of medications is that it can cause statin-induced rhabdomyolysis. And this is where really your skeletal muscles are breaking down. And when they break down, they release myoglobin into the blood. That starts traveling through your blood, which hits your kidneys because your kidneys filters all your blood. When it goes to your kidneys, it damages your kidneys and causes renal failure. So this is looking like a promising answer, but it says decrease creatine kinase level. Whenever a patient has this condition where their skeletal muscles damaged, you would expect it to trend upward. So we're going to mark that one off. We have C, decreased low density lipoprotein level. So this is talking about the LDL level, which is like in a sense the opposite of that HDL level I was talking about in option A. So with the LDL level, we actually want this level to be low because it's a bad cholesterol. And this is the type of cholesterol, if you have it high, it builds up in your arteries and can cause fatty plaques, which could lead to massive problems. So we typically want this less than 100 milligrams per deciliter. And how you can keep the two straight, HDL and LDL, remember, we were talking about with HDL, we're talking about high density lipoprotein, we want that high. With low density lipoprotein, we want that number low. So we're going to mark that out because that tells us nothing about what's going on. And plus, we want it low. So that's an okay finding, doesn't send off alarms. And then lastly, D, increase creatine kinase level. And of course, that's our answer because we've ruled out everything else. But why is it our answer again? Creatine kinase, CK, that is released whenever we have damage to our muscles. And here, unfortunately, the statin is causing our patients problems. So because of that, that lab's going to be checked and that would send off alarms. And when we get that result back, we'd immediately want to report that. And sometimes this level can be like 10 times the upper limit of what your CK level would be. So that would definitely point that the statin is causing muscle injury. We want to discontinue it. This question says, as a nurse monitoring a patient on a continuous IV heparin drip, you're observing for signs and symptoms of adverse reactions. Select all the signs and symptoms that would indicate the patient is experiencing an adverse reaction to this medication. So we're going to have multiple answers for this question. A, hematuria. This is where you have blood in the urine. So let's go back and quickly review what heparin is. Heparin is an indirect thrombin inhibitor. So it's an anticoagulant and it helps treat or prevent blood clots. It doesn't bust up an existing clot. So it's going to prevent new ones from developing, or that current one that's there is going to prevent it from getting bigger. And when a patient is on a continuous IV heparin drip, we have to be meticulous in monitoring a certain blood level known as the PTT level. This stands for partial thromboplastin time. So remember, with heparin, we're monitoring the PTT level. Don't confuse it with warfarin, also known as Coumadin, because with that, we monitor the PT-INR. Therefore, as we monitor this PTT level, we want to make sure it's within a certain range. And this is going to be based on the protocol that the healthcare provider has ordered for why this person needs a heparin drip. And it really varies. Like, are they on this heparin drip because we're treating pulmonary embolism, or it's after a myocardial infarction? It varies. So you're going to look at the PTT and you're going to either increase the drip, give them a bolus, leave the drip alone because they're good, or you may have to turn the drip off. And the reason we want to keep this PTT level within that therapeutic range is because, number one, we want to prevent them from clotting. or developing new clots, so we don't want it too low. But we don't want it too high, because if it's too high, we've really prolonged their clotting time and they're at risk for bleeding. So hematuria would definitely be an adverse reaction to heparin. And hematuria can really vary. Whenever you're first starting out, you may think of, okay, hematuria, I'm going to see some pronounced, crazy, bright red blood in their urine. I know that they're going to have hematuria. No, it can be very subtle. It can just, sometimes, one time I had a patient who was started on heparin, and I just noticed this very subtle change to their urine. It just got this very little light pink color, and that was hematuria. So always make sure you're assessing that urine very closely. So A is an answer. Then B, decreasing platelets. So is that an issue if your patient is on heparin? You're starting to see those platelets trend downward. The answer is yes. Because one thing I want you to take away from this whenever you're studying heparin is that heparin can cause a condition called heparin-induced thrombocytopenia. And this is where, in a very simplified way, what happens is that your body creates these antibodies against the heparin and the platelet factor 4. So whenever it does that, you start to get these small clots forming, which is going to really undo everything we're trying to do with our heparin therapy. And it's going to cause our platelets to decrease. So you definitely want to monitor those platelets whenever a patient's on heparin. If that happens, we can immediately discontinue that heparin. If they need still anticoagulation, we can give them a direct thrombin inhibitor like argatroban. So B is definitely an answer as well. Then C, increased glucose. Heparin doesn't really mess with your glucose, so we're going to not have that as an answer. And then D, low hemoglobin and hematocrit. Hemoglobin and hematocrit are blood levels that we look at to tell us the patient's status of their blood in their body. For instance, if it's too low, they may need blood. Now, if you see that a hemoglobin and hematocrit is low in a patient taking heparin, that should be sending off bells, because the patient may be bleeding somewhere. It may, a lot of times it's not just outward bleeding. You see something, it's inside, it's in their gut or some other place. So if we see that that is getting low, we definitely want to investigate that, and that would be an adverse reaction because it can cause abnormal bleeding. So D is an answer as well. Then E, positive stool guaiac test. So this test is a test that checks for blood that maybe is not pronounced to the human eye that's in the stool. It's also known as a fecal occult stool test. And if it's positive, that means that there is blood in the stool. So we know that heparin can cause abnormal bleeding. And if we have positive stool test, that's not good. So that could be an adverse reaction. So that would also be the answer as well. So our answers are A, B, D, and E. Here the question says, the nurse receives an order to draw a peak level on a patient prescribed gentamicin via intravenous IV infusion. The infusion will take 30 minutes. When is the best time for the nurse to draw this peak level? So before I go through the options, let's for a moment talk about gentamicin and peak level. So gentamicin is an antibiotic part of the aminoglycoside family, and it mainly targets gram-negative bacteria like Klebsiella, Pseudomonas aeruginosa, but it can also target gram-positive like Staphylococcus. And how it works is it inhibits protein synthesis of the bacteria. Now, one thing about these aminoglycosides that gentamicin is part of is that they can really affect your kidneys and your ears, particularly your hearing. So if you can't remember anything else about aminoglycosides, look at the name. We have amino, N-O, glycoside. And remember that in that O, that's going to tell you the big thing about these drugs. They are nephrotoxic and they are ototoxic. So it affects your kidneys and your ears. And with this, particularly with gentamicin, we have to get this little narrow therapeutic range. We don't want them too low because that means that this medication is not going to work, and we don't want them too high because we can damage their kidneys and their hearing. So we want to measure a peak level. Also, you can measure the trough level. So peak level, think of a mountain peak. What is that? That is the highest part of that mountain. So a peak level on a medication is its highest concentration of how it's working. So we need to determine when's the best time to draw this level at its highest time. So let's look at our options. A, immediately before the next dose of gentamicin. Well, if they're going to literally be getting this medication and we go in and draw, is that medication going to be at its peak? No, that's more of the trough level. That is the trough, the lowest part. That is when you would want to draw your trough. So that's not an answer. B, 4 hours after the infusion is complete. No, that doesn't tell us anything because medication's already worked in. It's IV. It's going to go in there pretty fast. So that's not the answer. Then C, 30 minutes after the end of the infusion. So here it's telling us, we're going to give the 30-minute infusion of the gentamicin. Then once it's done, we're going to wait 30 minutes again and then draw the peak. And that is correct. That's how we would know that this medication is at its highest concentration. So D, we can go ahead and mark that off, 30 minutes before starting the infusion. That's, again, more like a trough level because we're doing it right before. So whenever you're answering these questions, make sure you're paying attention to the route that the medication is going to be given because that does alter when you would particularly do your peak. For instance, if we gave this IM, we would want to do a peak 1 hour after we give the injection. But here, since it's IV, and it's a 30-minute IV infusion, we're going to have our infusion run 30 minutes, and then 30 minutes later, we'll draw and get our peak. This question says a patient is prescribed diltiazem for treatment of a cardiac disorder. Which findings below would require the nurse to hold the ordered dose of diltiazem and notify the healthcare provider for further orders? Select all that apply. So again, we're going to have multiple answers. Here we want to select options that would require us to hold this dose of diltiazem. We wouldn't want to give it because it would cause issues. So A, a blood pressure of 158/98. This is high, it's a little hypertensive, but we're talking about diltiazem here. This is a calcium channel blocker. And how it works is it blocks the L-type calcium ion channels in like our heart and body, which is going to dilate our vessels and relax them, which we're going to get some dilation of our vessels. When we dilate our vessels, what's that do to our blood pressure? It decreases it. So that's okay. That's nothing major because once we start this, that'll be okay. It doesn't require us to hold the dose. B, ECG shows 3rd degree atrioventricular block. That's a 3rd degree heart block, also known as a complete heart block. That is a horrible finding. And that is not a reason that diltiazem is ordered. Diltiazem can also treat cardiac disorders because it affects the cardiac nodal tissue in your heart. It's used for like fast dysrhythmias like SVT, supraventricular tachycardia, or atrial fibrillation. But how it works, it can slow your SA node and your AV node. And whenever we have a 3rd degree heart block, we already have problems with like our AV node, and we wouldn't want to further slow that down. So if you see a 3rd degree heart block and you're ordered to give them diltiazem, you would definitely want to hold that dose, contact the healthcare provider, and see where you need to go from there. So B would be an answer. Then C, the ECG shows atrial fibrillation. That's actually one of the indications why we would start this type of medication because it can help treat it. So that's not a reason that we would hold it. It's probably that cardiac disorder that they're getting treatment for, like how the scenario told us. And then D, a heart rate of 46 beats per minute. This is slow. This is bradycardic. In an adult, a normal heart rate is about 60 to 100. And diltiazem, when you start the medication, particularly if you're doing like a continuous IV drip or even the PO forms, one of the things you always have to watch and monitor, number one, is their blood pressure, making sure they're not getting hypotensive, and you have to look at that heart rate. So they're already slow. We wouldn't want to give them this medication because, again, this affects how our SA node works, makes it slow. So that would be one of our answers. So our answers are B and D. This question says a 42-year-old patient is taking captopril to manage blood pressure. Which finding below requires immediate nursing action? A, urinary output is 300 mLs within the past 4 hours. So we're thinking, okay, over the past 4 hours, how much urinary output is that hourly? Well, when you divide that out, 300 divided by 4, you get 75 milliliters per hour. Well, is that bad? In an adult, you want it at least like 30 to 35 mLs per hour. So that's within range. So we're going to go ahead and mark that off. B, patient has a persistent dry cough. We don't like patients coughing. That could be an issue, but let's Let's quickly talk about what captopril is. Captopril, notice that generic name ends in pril. Which family is that? That's our ACE inhibitors. ACE stands for angiotensin converting enzyme inhibitor. So what this does is it inhibits that enzyme. And what it's going to do in a nutshell is it's going to inhibit angiotensin 2 from being activated, and this is a huge vasoconstrictor. So when you have blood pressure issues, which is why this patient's taking it, we don't need vasoconstriction because vasoconstriction increases blood pressure. We need some dilation going on. So if we can block that enzyme, we can cause dilation. In addition, ACE inhibitors can also cause your kidneys to excrete water and sodium. So that helps manage fluid volume, which is great, like if you have heart failure or even managing your blood pressure as well. But a side effect of that is that it can increase potassium, so it can cause hyperkalemia, and I want you to keep that in the back of your mind. Now, circling back to this persistent dry cough, and we're talking about ACE inhibitors. So ACE inhibitors normally inhibit ACE from working. However, whenever we have ACE working, where it's not being inhibited, we get the conversion of angiotensin 1 into angiotensin 2. Now, it also plays a role with another substance called bradykinin. It inactivates it, so we don't have, like, in a sense, the buildup of it. But when we throw in the ACE, we're going to inhibit that process from going to angiotensin 1 to angiotensin 2, so we're not going to inactivate that bradykinin, so that substance increases. And they think that the reason that patients get this dry, persistent cough is because of this substance being able to increase in the body because we've blocked that conversion process. And when it builds up, it leads to this dry cough. So that is not an answer because we expect that to happen. It doesn't require immediate nursing action. We can notify the healthcare provider, tell them they discontinue the ACE, and they can maybe put them on an ARB or something else. Next, C, ECG shows tall peaked T waves. Okay, anytime we are seeing something wrong with the ECG, we definitely want to stop and think about that for a second. So I pointed back when I was talking about option B that ACE inhibitors can cause hyperkalemia because they cause the kidneys to retain potassium. And in hyperkalemia, is that an ECG change that can happen? The answer is yes. So whenever you have a high potassium level, it can cause a change to the T waves where they get tall and peak. So that's a classic sign of hyperkalemia. So that's going to be our answer, but let's look at D and why it's not the answer. It says patient has a negative Chavatstik sign. With Chavatstik's, it has a C in it. Remember, it's associated usually with calcium levels. Whenever we have hypocalcemia, where calcium levels get low, it can lead to these abnormal twitching that we find. And how you can check for it, I have a video here. You can actually see what a positive, negative sign is, but you will be testing cranial nerve 7. You will tap on the masseter muscle and you get this involuntary twitching of the face on that side that you tap. That's a positive Chavatstik. So that's why that would not be an answer, because that is seen with hypocalcemia and doesn't really have anything to do with ACE inhibitors. This question says, EMS calls in to report that they are transporting a patient to you who ingested ethylene glycol. Prior to the patient's arrival, what medication will you have readily available? This question is pretty much wanting to test your knowledge on if you know the antidote for ethylene glycol. So ethylene glycol is a very toxic substance. It's found in antifreeze. And what happens is that a person ingests it and then an enzyme called dehydrogenase breaks it down into toxic substances, which in a sense shut down your body and can cause death. So we need to know the medication or hence antidote that can prevent that enzyme from doing that. Therefore, let's look at A, option A, acetylcysteine. Well, just from your memory bank, you want to remember that that is not the antidote for ethylene glycol. That is more for acetaminophen, like Tylenol here in the US. So it wouldn't be A. B, naloxone. That is, a lot of people know it as Narcan. That is for opioid overdose, so not for this. And then C, deferoxamine. That is actually for iron toxicity. And a little quick blip on how I remember that is look at, it's deferoxamine, and then notice it has the FE in it. What is like the number or the symbol for iron, it's Fe, and that's how I remember it's for iron toxicity. So maybe that helps you. And then we have D, fomepizole, and that's our answer because we've eliminated everything. So fomepizole, how it's going to work is it's going to prevent that enzyme from being able to break down the ethylene glycol and get all the toxic substances in our body, which in a sense will kill us. So our answer is D. Here it says a patient with heart failure is prescribed digoxin and furosemide, which that is Lasix. The nurse knows that what finding below would increase a patient's risk of developing digoxin toxicity. Is it A, magnesium level of 1.8 milligrams per deciliter? So think back to magnesium. We know that it has a little narrow therapeutic range it needs to be in. We throw mag off, we can definitely cause problems, but I'm thinking more like torsades, you know, if we get magnesium too low. A normal is anywhere between 1.5 to 2.5, so we're within that range. I'm not concerned about that one, so we're gonna mark that off. Then we have B, potassium of 3 milliequivalents per liter. So this potassium level is a little bit on the low side. Normal is about 3.5 to 5. But does this increase a patient's risk of digoxin toxicity? Well, let's talk a little bit about digoxin and furosemide for a moment. Digoxin is a cardiac glycoside. A lot of times it's used for heart failure because it's going to slow that heart rate down but help it pump more efficiently, which is exactly what a person in heart failure needs. Their heart muscle is weak. Now, the thing about digoxin is that it has a very narrow therapeutic range. It's about 0.5 to 2 nanograms per milliliter. Anything greater than 2, we start getting into toxicity territory. And there's certain risk factors a patient can have that will increase the risk of developing this. Like if a patient's elderly, they have renal insufficiency, or they have an electrolyte imbalance, such as a potassium imbalance where you have hypokalemia. Now, whenever you throw furosemide in with digoxin, you can have a recipe for possible disaster, especially if you're not supplementing them with potassium. Because let's talk about furosemide for a moment. This is a loop diuretic. It acts on the loop of Henle, specifically that thick ascending part within the nephron. So that's where it gets its name. And what diuretics do is they take extra fluid that's in the blood and they tweak that fluid by shifting around ions and other things, and they put it in the filtrate, and then you urinate that urine out. And depending on what part of the nephron it's working on and the type of diuretic we're talking about will depend on what type of electrolytes it's shifting around. Now, loop diuretics particularly, they inhibit the reabsorption of sodium, potassium, and chloride. So sodium, potassium, and chloride are not going to be reabsorbed back into the bloodstream. It's going to stay in the filtrate. That water, the sodium being not reabsorbed, but going back in the filtrate is going to pull water into the filtrate so you can urinate it out. But unfortunately, there goes our potassium as well. So loop diuretics are notorious for dropping your potassium levels for the patient experiencing hypokalemia, which could increase digoxin toxicity. Okay, let's look at why the other answers are not it as well. So our answer is B. Okay, C, a BUN of 15 milligrams per deciliter. This shows us the patient's renal function, and that's actually within range. Normal is about 5 to 20 depending on the lab. So that's not the answer. Then we have D, albumin of 5 grams per deciliter, and this is actually within range. A normal is about 3.4 to 5.4. And this is a protein that can tell us maybe if we have a liver problem or a renal problem, and doesn't really affect digoxin. So that's why that is not the answer. This question says a patient is scheduled to take a dose of warfarin, which is Coumadin, at 1800 for preventative treatment due to atrial fibrillation. The patient's INR level is 6. As a nurse, you will A, administer the dose as scheduled. Okay, we have warfarin. Warfarin is a vitamin K antagonist. It is an anticoagulant, so it's going to help prevent or treat blood clots. Again, it does not bust up clots. And with this, we have to monitor a PT INR level, particularly that INR level. It really depends on why the patient is taking warfarin, where we want the INR level, but normally we want it between 2 to 3. Sometimes it may be a little bit higher if the patient is really at risk for clots, or let's say maybe they're taking it for a mechanical valve. It really depends. but generally speaking about 2 to 3. So when you see an INR level of 6, you're like, hold up, that's not good. So we would definitely want to, intervene, contact the healthcare provider, and see what we can do about this. So are we going to administer this dose as scheduled? No, because we're going to make their clotting time be prolonged even more, and they can have like a brain bleed or some catastrophic bleeding event. So we wouldn't do that. B, double the dose? Absolutely not. That is like out of the scope of practice of the nurse. We don't prescribe medications, so that's not the answer. C, hold the dose and notify the healthcare provider. Yes, that would be the answer. And the reason D is not is hold today's dose, but administer tomorrow's dose as scheduled. Well, on the surface, that may sound like a good idea. It's like, oh, I'll just skip this dose and give the dose tomorrow. But again, that is completely out of the scope of practice of the nurse. We don't make that type of decision. So the best answer would be C. This question says your patient has been prescribed cefazolin to treat an infection. Before administering the medication, you are assessing the patient's medication allergies. Which medication allergy, if verbalized for the patient, requires you to hold the prescribed medication and contact the prescriber for further orders? Is it A, gentamicin, B, erythromycin, C, penicillin, or D, ciprofloxacin? Cefazolin is part of the cephalosporin antibiotic family. Now, one thing you want to remember about this family is that they're a little bit similar in their chemical structure to another group of antibiotics known as the penicillin family, because they both contain the beta-lactam ring. And there is this cross sensitivity that can happen. So if a patient tells you, hey, I'm allergic to penicillin or any other medications in that family, you don't want to prescribe them these type of cephalosporins because they could also have a reaction to them. So our answer is C. Okay, so that wraps up this review. If you'd like to watch other videos that cover different types of questions, you can access them in the link below.